Board.
Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Antimicrobial Stewardship in the Community, Waiting Just Below the Surface. Following the webinar, please be sure to follow the instructions alongside the webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free NC CE credit. Our speakers today are Dr. Jacinta Chen, who's currently an infectious disease clinical pharmacy specialist at Novant Health Presbyterian Medical Center in Charlotte. She attended pharmacy school at Temple University School of Pharmacy, then went on to complete her PGY1 residency at University of Illinois at Chicago, followed by an infectious diseases residency at Advocate Christ Medical Center in Oak Lawn, Illinois. And Dr. Sarah Green, who is currently a clinical pharmacy specialist in infectious diseases and member of the Novant Health Antimicrobial Stewardship team at Novant Health Forsyth Medical Center in Winston-Salem, North Carolina. Sarah received her Bachelor of Science degree in Microbiology and Genetics from North Carolina State University and her PharmD from the UNC Eshelman School of Pharmacy. She completed a PGY1 pharmacy practice residency at WakeMed Health and Hospitals in Raleigh, North Carolina. Her clinical interests include diagnostic stewardship and gram-negative resistance. I will now turn it over to our first speaker, Dr. Chen.
All right, thank you everyone for attending. So we will be talking about antimicrobial stewardship opportunities in the non-acute setting. The objectives for the presentation are to identify reasons supporting the need for antimicrobial stewardship in outpatient and nursing home settings, to recognize the CDC core elements for outpatient antimicrobial stewardship and stewardship for nursing homes, identify common disease state targets for these programs in both of these settings, to develop facility-specific strategies for starting such programs, and to define ways to integrate antimicrobial stewardship into daily practice.
So over the last decade, the concept of antimicrobial stewardship has definitely become widespread with increased support and guidance by government and accreditation agencies. Starting in 2006, our CDC released the first of several guidelines, this one on management of multi-drug resistant organisms in healthcare settings. In 2009, the CDC launched their Get Smart for Healthcare campaign. And so this campaign occurs annually and focuses on raising awareness about appropriate antibiotic prescribing and resistance threats. In 2015, the CDC went even further and identified antimicrobial stewardship as a key strategy to reduce antimicrobial resistance. In 2014, this is where we started to receive specific evidence-based guidance on what is required to implement and maintain an effective antimicrobial stewardship program in the hospital setting. In 2015, the CDC extended its recommendations to the nursing home, creating core elements guidance there. And the Centers for Medicare and Medicaid Services proposed the first conditions of participation requiring antimicrobial stewardship in long-term care facilities. The White House also came on board in 2015 with their National Action Plan for Combating Antibiotic-Resistant Bacteria. 2016 was also a really big year. So the Leapfrog Hospital Survey System added compliance with our CDC core elements for antibiotic stewardship to their survey. The CDC again extended their recommendations and their core elements, producing recommendations for the outpatient setting. And then the Joint Commission came on board, and so they proposed their antimicrobial stewardship medication management standards. Our ID clinical groups, the Infectious Diseases Society of America and SHEA, they also released a stewardship guideline providing guidance on how to implement an inpatient program. And the National Quality Forum also published their own best practice recommendations for antimicrobial stewardship. And then this momentum continued even into last year. And so this was actually a really big year for antimicrobial stewardship. 2017 is when we started to see the Joint Commission have their go live for the antimicrobial stewardship medication management standards. And so those of you that actually participated in a survey last year definitely saw the questions around your stewardship program as part of that audit. And then additionally, at the end of 2017, November 28th, actually, CMS actually implemented phase 2 of their antimicrobial stewardship program requirements for long-term care facilities. And so you can see that a lot of work has definitely been done into addressing inappropriate antibiotic use within hospitals. And it's definitely important to focus on our acute care facilities. About 38.5% of our total antibiotic usage is in the inpatient setting. But it's important to remember that this is only the tip of the iceberg. So antibiotic usage in any setting contributes to the development of antimicrobial resistance. And right beneath the surface, we have antibiotic prescribing in the outpatient and long-term care settings. You saw that more focused guidelines and oversight are being developed to address antibiotic use in these areas. But one final major arm of antibiotic consumption is involved with livestock and animal feed. About 80% of antibiotic consumption in the US is attributed to use in this manner. So the potential influence of agricultural antibiotic use has come under scrutiny, and hopefully we'll see more regulations on use in this area. But that's a topic for another presentation. So at this point, I will turn it back to Jacinta, and she's going to talk to you about antimicrobial stewardship in the community.
So we will be talking about inappropriate antibiotic prescribing, really, as that's why we need antimicrobial stewardship. This graphic summarizes some of the larger drivers of inappropriate prescribing. There are many factors that go into it, so these are just some of the more common ones that are identified. Lack of communication skills, patient expectations, infectious diseases knowledge base, understanding the threat of resistance, and unawareness of resistance. These factors are then further complicated by psychosocial factors, which we'll also be discussing throughout. Looking at community antibiotics by the numbers, 80 to 90% of human antibiotic use is in the outpatient setting. Half of all outpatient antibiotic use may be inappropriate. And I want to use caution with the word inappropriate here, because that sounds like an alarming number, and it is, but inappropriate can mean the wrong drug, dose, or duration. About 30%, though, of antibiotics may be totally unnecessary. In terms of ED visits, 1 out of every 5 is for an adverse drug reaction related to antibiotics, and this also does significantly impact our pediatric population. In terms of looking at money, and this is in 2009 dollars, $6.5 billion was spent on antibiotics, and that is only in the outpatient setting. There were another $3.5 billion, only half as much, which were spent on hospitalized patients. So moving on to focus on the core elements of outpatient antimicrobial stewardship. As Sarah outlined in the timeline, there have been a lot of national societies coming forth with recommendations for stewardship. And one such from our Centers for Disease Control came forth with core elements for the outpatient setting. Taking a further look, first we'll be looking into what it means to be committed. So some of the recommended ways to show commitment are listed here. Displaying public commitments of support in public areas, antimicrobial stewardship related duties and position descriptions, commitment of all clinic staff members to set patient expectations. And then what we have displayed on the right is an example from the CDC of a free poster that they can provide that provides some of the language about commitment. So talking about these more in depth, when we're talking about all staff members being committed to antibiotic awareness, really from the front desk to the exam room, everyone should be aware of the clinic's commitment to using antibiotics appropriately to set the expectation for the patient. There also needs to be commitment at the facility or system leadership level. Implicit in the core element is the need for the right people. You're trying to move mountains, so you're going to need people who are both dedicated to the pursuit, but also in the right position within the organization to affect change. So you might need some friends in high places who are also passionate about stewardship and what it means for patient care and safety. Writing and displaying public commitments of support, such as that example that's provided on the right, demonstrate clinician commitment to appropriate antibiotic prescribing. This includes antibiotic stewardship-related duties, and communication with all staff members, as we've already reviewed. So every person involved in a patient's care, whether directly or indirectly, can act as an antibiotic steward. So really, we're all stewards, we just may not be aware. Looking further into the role of commitment posters. This is a study that used commitment posters to change antibiotic prescribing as a low-cost method that also incorporates behavioral psychosocial influences. The intervention was a poster-sized commitment letter. It was displayed in exam rooms. It was similar to what we previously showed, where it just explains, we're here to take care of you, and sometimes that care involves an antibiotic, and other times it doesn't involve one. And it really impressed a compassionate nature to the patients. So in this study, they compared rates of inappropriate antibiotic prescribing for acute respiratory infections, as most of those are viral in etiology and don't require any antibiotics. This graph shows from baseline to final for both poster and control groups. And what they found was an absolute difference of about 20% decrease in inappropriate antibiotic prescribing in the poster group. And what they commented on was about the interpersonal factors that affect prescribing. So traditionally, these aren't addressed in studies. It's assumed that people are rational beings motivated by rational forces. However, just living in the world tells us that that isn't true, and that humans are motivated by very complex interpersonal drivers. So we'll be looking at some other studies that touch on these subtle cognitive mechanisms, the different psychosocial and professional factors that go into prescribing, and not just the assumption that feedback or incentives are going to work. Moving forward on to action and policy for practice. So really what that means is implementing at least one policy or practice to improve antibiotic prescribing. Just highlighted below are some potential interventions: provider education, patient education, provider feedback, creating guidelines, and other such. There's a multitude, and there are definitely more than can fit on any one slide. What's interesting is that using these in combination can help harness power greater. So here's an example if we were to do a proposed intervention where we wanted to focus on provider education. We can educate providers on communication skills for patient education and expectation of antibiotics, and also about delayed prescribing, selecting use of antibiotics in viral upper respiratory tract infections as a specific target. After collecting data, then there's a plan for provider feedback that is showing providers how they're doing in regards to appropriate antibiotic prescribing. This is just one example of many different types of interventions that could be put into practice. So whatever policy or practice that you want to implement, it should be achievable, measurable, and sustainable. We want to make sure your goals are reasonable, especially if you're starting something new. It's important to have some early wins. To be able to provide feedback, you need to have measurable things you can actually track. So what data are you capable of collecting? How automatic or manual is the process going to be? And then for sustainability, is this policy or practice going to be able to be continued with ease, or is it too intricate to maintain in the real world? So moving on to tracking and reporting, which really goes very closely with action for policy and practice. So tracking and reporting could be its own topic, and we're going to pull out some highlights related to how it's been used in community stewardship setting. There are a lot of similarities to how you would track and report in the outpatient to the inpatient setting and others, if you're already familiar. And you may also have heard of audit and feedback, which is another way tracking and reporting is sometimes referred to. So you want to know what outcomes you're going to track. Are we looking at facility or clinic goals? What specific initiatives are we going to track? Then there's the level of data to collect at the facility level or the individual clinician or other level. And then for feedback, how often are we giving it? Peer comparison, which we'll go into later on, and how that can be influential for behavior. And overall, what we're trying to do is affect a change in practice. So a lot of the available outpatient literature is on upper respiratory tract infection because that's a very common reason patients go to see a doctor. So I do want to say one thing is that this graphic may be misleading because it looks like it's a very straightforward path to change in practice. So what actually may happen is that you get to the feedback part and realize that perhaps our intervention didn't have the desired effect we wanted. But that's because it takes more than one action to really change practice, which is really changing the culture of when and how to use antibiotics. So looking at common stewardship outcomes, rates of overall antibiotic prescribing, appropriateness of antibiotic prescribing related to disease states, and antibiotic complications such as Clostridium difficile infections. Sources of data include extraction from the electronic medical record, manual periodic chart reviews, and performance data on existing quality measures. Feedback, which I definitely want to talk about more specifically, but that includes clinician level data back to individualized feedback, use of peer comparison, for example, selecting out top performers. And feedback also works both ways. So it's important to get feedback back from your clinicians on how to improve the quality and impact of the interventions. And then finally, just a few cautions. One is diagnosis shifting. So that is a practice that is called diagnosis shifting, and that occurs when a clinician manipulates a diagnostic code to justify prescribing an antibiotic. So for example, a clinician might record the code for pneumonia, which does require an antibiotic, when a patient really has acute bronchitis, which doesn't generally require antibiotics. So this can be missed when tracking and reporting only one high priority condition, such as looking at only acute bronchitis, whereas tracking the percentage of all visits leading to antibiotic prescriptions is not affected by diagnosis shifting. Other things to consider are if you have any underlying patient population differences. If you're comparing across a large clinic population, where are they similar and where are they different? If you are looking at smaller clinic level data, then you may be dealing with small sample sizes where a small denominator will influence the result that you have, and to take that in stride. So to speak more in depth about feedback, I wanted to review an interesting study here. They looked at behavioral intervention on prescribing rates for acute respiratory tract infection. There were 3 interventions that were done. There were suggested alternatives, so basically non-antibiotic treatments that would pop up when they went to prescribe an antibiotic. Accountable justification, which is the provider had to put in a free text reason for why they were prescribing an antibiotic, and this appeared in their medical record as an antibiotic justification note. And then peer comparison. So they got monthly emails comparing individual prescribing compared to top performers. So clinicians were with the lowest inappropriate prescribing rates were told they were top performers, and everyone else got an email saying they were not a top performer. In this study, groups were randomized in a variety of ways to receive 0, 1, 2, or 3 of these interventions. And the researchers found that those interventions with a social component, so the accountable justification and peer comparison, were effective. For space purposes, I didn't include the graphic that looked at suggested alternatives because these were way more interesting. So, drawing your attention to these 2 figures, you'll notice that the overall trend is decreasing inappropriate antibiotics rates, even in the control group over time. We have this nice downward slope for both of them. But in the orange markers and the triangles and the circles, we see that, from day 0, it really starts to pull away from the control group, and they found these differences to be statistically significant as well. So from this, it matters not just that you give information back to your providers, but it matters how you give it back. You really need to capture their attention, and then you need to continue to provide feedback. You know, if we were to continue to look at these measures, but had stopped sending out the top performer emails, would there be a regression back to the control? So it's important to maintain, and it goes back to sustainability and picking a measure and intervention that is sustainable, such as a monthly email. So moving track slightly to talk about education and expertise. So education seems like a tenet of any stewardship endeavor. If you think back to the first slide on the drivers of inappropriate antibiotic use, ID knowledge base can be a factor. However, education is not limited to what we give to clinicians, but also we need to educate our patients and really the entire general population. So these items here are listed from the CDC Core Elements document, and they're fairly straightforward. But it's not often that knowledge deficit is the only barrier. We've already started discussing some of the complex behavioral components and studies that target the irrational human aspect of clinicians. So what really does improve antibiotic prescribing? This is kind of a difficult question to answer. These results are from a 2015 systematic review of existing literature on interventions to improve antibiotic prescribing in the community setting. They looked at multiple studies, and they found essentially a medium effectiveness for communication training skills and lab testing. So that included rapid antigen testing, procalcitonin, and C. diff PCR. And everything else was determined to be of low effectiveness. So provider education, patient mailers about when it's appropriate to use antibiotics, provider feedback, guidelines, restriction, decision support, which is leveraging your electronic health record to help you out with some of those decisions, and financial incentive even. And you know, it should be noted that there was a lot of heterogeneity in those studies, and the researchers came up with qualitative determinations. So there is no way to mathematically say what worked and what didn't work. So that's why in the list of what are potential ways to improve, it looks a lot like the middle column, because as we've already touched on, you know, these interventions may have worked less, but it could be because of how they were implemented and not the intervention itself that doesn't work. Although, you know, I think it's worth noting, I left off financial incentive, you know, one, because there's no data to support that. And I mean, to be honest, it feels a little slimy to include that as a potential intervention. So really, to try and sum up for education, it can mean a lot of things. It can be applied to both our clinician and our patient groups. Provider communication skills were identified as having a stronger impact on antibiotic prescribing. And we can see why that may be. Supplying our clinicians with these skills enables them to be better at providing education to parents. I think it's a bit blown out that all patients expect an antibiotic when they go to visit their doctor. Often patients just want to be heard. They want someone to listen. They want someone to sympathize with them. They want to be told they'll be okay. They're sick. And yes, there will be some sticklers who absolutely insist on that antibiotic prescription for a viral infection, but the general culture around antibiotic use isn't going to shift until people start talking about it on the individual patient level. So switching tracks, I want to focus on how community pharmacists can be involved in this work. 266.1 million antibiotic prescriptions were filled in 2014. So there is an extremely high prevalence as well of antibiotic resistance infections in the community. So our community pharmacists are really in a prime position to help with stewardship roles. They may be the first healthcare professional a patient sees. The community pharmacist can help set expectations about when antibiotics are appropriate. They can also help patients find symptomatic treatment within the pharmacy. They can promote vaccinations in otherwise healthy patients, and they can help determine whether documented antibiotic reactions are true allergies. The CDC has a lot of educational materials written to be given to patients, available on their website. Some of these materials are even free to order, and you get printed posters, but everything is available as color copies that can be printed out. So they have, is it virus or bacteria chart about when antibiotics may be appropriate. And then some others that I've listed below that really just kind of highlight at the patient level when antibiotics may be appropriate and what are some of the side effects of using antibiotics when they're not. So all of those things, you know, those are great. And if those interventions were to be studied alone, they would probably have a low impact. They're rather passive, and they require a lot of time and effort and commitment that may not be feasible in every community setting. So what if we could take that even further? And this study looks at just that. So this is a collaborative practice agreement to leverage the education and training of pharmacists. They were able to screen for, and if appropriate, provide antivirals or antibiotics per protocol for influenza or group A strep pharyngitis. Looking briefly at the methods that they used for influenza, identification of a symptomatic patient. So this would be in a community pharmacy, a patient who looks like they have the flu comes up, and then the pharmacist assess if they are eligible for screening and if they would like to be screened. There are a series of questions that the patient answers. If everything is still a yes, the rapid influenza test is performed. There's an assessment for automatic referral based on specific guideline, very protocolized criteria. And then based on the test result, if it was positive, then the pharmacist could fill a prescription for oseltamivir, and if it was negative, they could recommend supportive care. Very similar for the group A strep group, identification of a symptomatic patient, probably someone coming up to the counter saying, hey, what do you have for a sore throat? There's a scoring tool that helps guide when it was appropriate to perform a rapid group A strep test. Then based on the result, if it was negative, no antibiotics were given, supportive therapies were recommended, and if it was positive, then a prescription per protocol could be generated. And then again, the patient was assessed for automatic referral. So in some situations, if the patient is very sick, they would be referred automatically to an urgent care emergency department. Let's look at some of the results from this study as very interesting, I think. So for the influenza group, 121 patients were screened, 75 met the criteria for inclusion, and 8 or 11% had a positive test. Looking at group A strep for the same, 316 were screened. They tested 273 and found 48 of them to be positive. So let's compare that to looking at other rates of prescribing for antivirals or antibiotics for these conditions if they were to go to see their provider in the office. And I really wanted to highlight these in particular as interesting because we're looking and patient satisfaction is still pretty high, even though not that many people got a prescription for an antimicrobial. Looking at the proportion of patients who either presented outside of normal hours or didn't have a PCP, that's a fairly big number that otherwise would have ended up at an urgent care or an emergency department, where likely they would have been prescribed an antibiotic. So some take-home messages for this. There are complex factors that contribute to the problem of inappropriate antibiotic prescribing. So the more complicated the issue is, the more sophisticated our approach has to be. And by sophisticated, I don't necessarily mean very intricate interventions. We saw one where a poster that said, hey, I'm your doctor and I'm committed to using antibiotics appropriately, put on the door in the exam room, improved appropriate antibiotic prescribing. We're looking at an email that goes out once a month that says, you are a top performer or you are not a top performer. What is sophisticated are the approaches that those interventions rely on. Implementing policy or practice change can target multiple things at once. So try and get the biggest bang for your time dollar. Be smart when choosing your targets and outcomes tracking. If this is the beginning, you may need some early wins to get more people on your side and on board the stewardship train. Be even smarter about how you deliver the feedback. But don't be afraid to dream big and believe you can have an impact on antimicrobial use. If you don't do it, who will? And really, the numbers speak for themselves. This is from the CDC as well. You know, we're talking at least over 2 million illnesses and 23,000 deaths from antibiotic-resistant infections. So with that, I thank you for your attention, and I'll be turning it over to my colleague, Sarah, to talk about long-term care facilities.
Thanks, Jacinta. So again, we are switching gears to focus on antimicrobial use in the long-term care facility patient. Again, right below the surface, we have 1.5 million long-term care facility residents in the United States alone, and 10%, or about 150,000 of those, receive an antimicrobial every single day. When you look at this annually, up to 75% of all nursing home residents will receive an antibiotic. And unfortunately, studies that have gone back and evaluated the appropriateness of this prescribing have found that, you know, up to 75% of prescribing in this patient population was either inappropriate or unnecessary. And again, I want to mention, just like Jacinta did, that the definition of inappropriate is kind of a strong word. And so a lot of times inappropriate means that it potentially was not the best drug, or, you know, the wrong indication. Potentially the dose could have been optimized, or the duration, or none of these things were documented. So lots of room for some low-hanging stewardship interventions. The other thing to consider with our residents of the long-term care facilities is that they often receive an antibiotic prescription when they make an ED visit, or they go out into the community and see their specialists. And so again, a lot of opportunity here to help optimize antibiotic prescribing when it comes to transitioning these patients from one care setting to another. So long-term care facilities, they're very unique in terms of their patient population, as well as their challenges for infection control. The average length of stay in this care setting is about 2.3 years. So during that time, several resident and environmental specific factors may increase the risk of bacterial colonization and subsequent infection in these patients. So studies have looked at exactly what the rates of colonization are in these long-term care facilities, and they have found that up to 50% of residents are colonized with at least one resistant organism, and that there are definitely higher rates of CRE in nursing homes compared to the acute care setting. So about 30% of residents, or 1 in 3 residents, are colonized with a carbapenem-resistant Enterobacteriaceae. So again, these are organisms that are resistant to our most broad spectrum agents, compared to only 3% of patients in acute care facilities. And then I think we're all familiar with MRSA, or methicillin-resistant Staph aureus, and studies have shown that about 60% of patients in nursing homes are colonized with MRSA. Looking at the increased risk for colonization, so again, these are very patient dependent as well as environmental dependent. And so depending on the overall functional and nutritional status of your patient, you may have substantial skin and mucosal breakdown that allows for colonization of these organisms. Oftentimes there are multiple medical devices present. So we know that any patient that has, you know, hardware, Foley catheters, feeding tubes, any of this, plastic or metal, bacteria love to colonize those areas, live in those areas, and just hang out as long as they're present. And then when you have these colonized organisms, when your patient ends up getting recurrent urinary tract infections, and so this is actually pretty common amongst this patient population, they often, are either treated in the nursing home itself, or they are transferred to the hospital, where they receive even more antibiotics that make these colonized organisms resistant. And as far as translating from colonization to infection, these patients are often of advanced age, they're frail, And immunosenescence puts the patients at risk for reactivation of chronic latent infections. These include tuberculosis and herpes zoster. And then significant comorbidities, these even include cognitive impairment. They create a situation where the resident is dependent on multiple activities of daily living. And so that dependence increases their overall healthcare exposure and increases their risk of infection. So again, they're colonized kind of due to hardware and, physical illness, and then that only further contributes to actual infection. And then once they become infected, we all know patients who get antibiotics are definitely at an increased risk for C. difficile infection, and this is especially true in long-term care facilities. So up to 30% of residents who receive an antibiotic in this setting will end up with a C. diff infection. And these patients, because of those factors that we've discussed, are much more likely to have a C. diff recurrence or a complication of their C. diff infection. One of the other things that just kind of complicates this issue is, there are a lot of barriers to performing antimicrobial stewardship in the long-term care setting. So the overall prevalence of antimicrobial stewardship programs in long-term care facilities varies greatly by state. So this ranges from anywhere as low as 25% to up to 60%, depending on where you're located. And there's several unique factors to setting up antimicrobial stewardship in this setting. So one of the most important is the lack of literature. So we don't have great studies that say, hey, do this and you can get this outcome. And so without those validated studies, we don't really have robust strategies specific to long-term care antimicrobial stewardship. Additionally, unlike the acute care setting, there's not likely to be an infectious disease trained physician or pharmacist on staff. Another unique challenge is overcoming resident and family expectations for antibiotic use. And so Jacinta touched on this, but oftentimes, patients and their family members are very involved in their care in these settings. And it can sometimes be difficult to explain to them, why certain infections and certain fevers don't require an antibiotic. So lots of room for education there. For certain disease states, even diagnosing the infection can be difficult. Again, we don't have a physician on staff, and so depending on the level of care, it may be hard to assess, the patient's change from baseline and the validity of their symptoms. And then finally, there are definitely fewer on-site resources, and particularly there usually is not a microbiology lab present in your long-term care facility. And so this definitely affects your turnaround time for cultures, if you get any. And these are invaluable in the inpatient setting to antibiotic selection, but also leads to some difficulty in determining whether an infection is bacterial or viral. But don't despair. So we are definitely seeing more strategies starting to be described in the literature. There may or may not have outcomes associated, but we're definitely, taking what we've learned from the inpatient and outpatient settings and applying them to this patient population. So, and one of the best resources, again, for stewardship, definitely are CDC core elements of antibiotic stewardship in nursing homes. And so I will be running through these core elements as well. So starting out with leadership commitment. So this is really important for all stewardship programs. So in the inpatient setting, those core elements require you to have physician champions for your board of directors to provide funding and resources dedicated to your antimicrobial stewardship program. And so they want to adopt a similar model for the long-term care facility. And so it's suggested that you have written leadership statements. So just put it in writing what your goals for your stewardship program are. And then including antimicrobial stewardship in your job descriptions. Communicating expectations regarding antimicrobial use, so not just monitoring, not just observing what's going on, but making it known that optimal use of antibiotics is expected at your facility. Looking at stewardship policy compliance, antimicrobial use and resistance data, having somebody assigned to do those things, so having some ownership. But ultimately, one of the big themes that we see throughout literature for long-term care facility stewardship is the idea of creating a culture of stewardship. And so you can see below in the graphic, there are so many people involved in the care of these patients. And as a result, there's so many people involved in stewardship for these patients. We'll talk more about this team. So moving from leadership directly to accountability. So again, going back to our interdisciplinary culture of stewardship and getting everyone involved. So this starts with the medical director, so our leadership support. And so he's going to set the standard. He's going to decide how antibiotics can be prescribed and monitored. And then moving to our nurses. So the director of nursing, this is the leader who's going to help us determine how patients are assessed and how that assessment is communicated to providers. And we will talk a little bit more about how nurses are frontline stewards in the long-term care facility and their assessment of the patient and how they communicate to the provider. These are key in making sure that the patient is receiving the appropriate antibiotic for an infection if they truly are infected. Pharmacist, again, you might not have a pharmacist on staff, but very often there is a consultant pharmacist available either in the health system or through a private organization that can join your team. And then infection prevention. So this is definitely a requirement for our long-term care facility stewardship programs. And so these are the people that are gonna help you mine your data. So they will help you during rampant flu seasons like we're having now, examine your C. diff outbreaks and make sure that proper infection control and hand hygiene is occurring at your facility. And then lab services. So this may not be on site, but enlisting laboratory support is invaluable. So an antibiogram, for those of you who may not be familiar, an antibiogram is an incredible tool for antimicrobial stewardship. It describes if you look at an organism, say E. coli, they look at all the E. coli that were tested or cultured over the last year and look at whether or not, specific antibiotics would treat that organism. And so basically this is what helps you determine what is an appropriate empiric therapy for your patient and also helps you monitor trends in resistance. And then finally, getting your providers on board, enlisting ID support, and then don't forget the family and patient. So everybody is accountable and everybody is involved again in this culture of stewardship. So we mentioned the fact that there might not be a pharmacist on site in the facility, but again, there's likely someone within the healthcare system or available for hire, even external consultant that could help implement and monitor your stewardship program. And so these pharmacists, it's ideal if they have specialty training in infectious diseases or antimicrobial stewardship. Definitely residency is an option, but there are also certificate programs available through infectious diseases pharmacy associations. So MAD-ID, or Making a Difference Against Infectious Diseases, as well as the Society of Infectious Diseases Pharmacists, they both have antimicrobial stewardship programs that are available basically to anyone. And so these programs are designed to, train your designated pharmacist to, again, support your antimicrobial stewardship program. And so we may not have as much data as we do in other care settings, but there have definitely been outcomes of pharmacist-driven stewardship programs specific to long-term care. And so these are very similar to what we've seen in the inpatient setting. So we start out with, a reduction overall antimicrobial use, and often, fluoroquinolones are targeted. So we've definitely seen that reduction in long-term care facilities. And then usually, or most often, when you have a reduction in antimicrobial use and fluoroquinolone use, you'll see a reduction in C. diff. So again, the data is growing, and pharmacists definitely play a key role. And then just like our outpatient stewardship, it's very important to develop policies and standard interventions to support optimal antimicrobial use. So the introduction, one thing that I will note here is that the introduction of new policies and procedures should be done in a stepwise fashion. And so this is one of the most important things to consider when you're consulted to start a stewardship program and you first go on site. So it's very, very important to kind of assess overall antimicrobial use, like what the patterns of use are and what your big areas of opportunity are, so that you can pick out your target intervention. And so starting with that target intervention and then beginning the the feedback, the reporting process, and then moving on from there. But again, a stepwise approach. Again, it's very important to prioritize interventions based on the needs of your facility and share those outcomes, especially successful interventions with nursing staff and clinical providers. And so some of the more common stewardship practices that we've seen in other settings are requiring an indication and duration. And so what's especially important here in the long-term care facility is requiring those indications and durations on patient transfer, because again, your patient can go out, see their specialist provider, come back with the prescription, and if you aren't clear on what it is for and how long it's to be given, there's the potential that they'll be undertreated or significantly overtreated. Standardized symptom evaluation, again, this is key in the long-term care facility setting. And the reason for that is we don't always have a provider on site. And so having a logical, standardized method to work up your patient and evaluate their symptoms and communicate those symptoms to potentially just an on-call provider will help them determine whether or not a patient needs an antibiotic and be confident that they're not missing a potential infection. Microbial stewardship, we've all heard of antimicrobial stewardship, but microbial stewardship is just as important. What I mean by that is using your test properly. And so we'll talk a little bit more about disease state specific interventions, but treatment of asymptomatic bacteria is definitely a hot topic in long-term care facility stewardship. So making sure that we're only ordering that urinalysis and that urine culture when we need to, and that another area of opportunity is not ordering test of cure for C. diff. And so we know that these patients will shed C. diff for long after they're treated, and so, or sometimes just be colonized. And so making sure that we're not testing or screening and treating when no symptoms are present. Performing an antibiotic timeout. There's lots of data to support doing this in the inpatient setting, but basically this is where, and this could be part of your daily review. So patients that have been on an antibiotic for 48 to 72 hours, taking a look at that regimen, taking a look at any lab data that you have back, any change in symptoms, and evaluating whether that antibiotic is still needed. So that timeout can be pharmacist-driven, but you also have the opportunity for other pharmacist-driven dosing protocols. And so pharmacists, definitely the medication experts on the healthcare team. This applies in the nursing home setting, and they should be the ones who are adjusting medications for renal or liver dysfunction, as well as potential drug interactions. So having your pharmacist involved, definitely important. And then lastly, we'll talk a lot more about disease-specific interventions. So I've titled this slide Disease-Specific Interventions, and I've listed out some low-hanging fruit. And so these are areas where that we commonly see infections in the long-term care facility and symptoms related to potential infections, and that there's a little bit of gray area around whether or not we need to prescribe an antibiotic. So you consider these disease states themselves low-hanging fruit, or you can apply your low-hanging fruit interventions to these disease states. It doesn't really matter. But urinary tract infections, definitely an area of opportunity. Several of our patients have Foley catheters in the nursing home, and we know that patients with any sort of hardware or medical device, that these devices can become colonized. And so often patients, well, once they become colonized, if you test them for if you perform a UA, there will be bacteria present. And so this is why a standardized screening tool, such as the one on the right, is very important to determining whether or not they truly are infected. And so this example is actually provided by the Agency for Healthcare Research and Quality, or AHRQ. Their website is actually listed on the bottom left there, but they have a nursing home antimicrobial stewardship guide. So again, specific to your nursing home population. And they have antimicrobial stewardship toolkits there. And these toolkits are amazing. They contain SBARs for nurses. So again, helping the nurses work up the patient to determine whether or not patient is infected and whether they should reach out to a provider. Pocket cards, training guides, all sorts of education material. But one of the things that I found most compelling were the individual algorithms they have for these specific disease states. And so starting at the top, you can see the outline here that talks about whether or not you need to initiate antibiotics. This one's for a skin and soft tissue infection. And so it very specifically lays out the changes that the nurse can directly observe that may indicate the antibiotic is needed. But it goes beyond that to list all these other disease states that may not necessarily require a change in prescription or an antimicrobial agent. And so the nurse can directly consider whether these rules apply, or if the patient really does need an antibiotic, it has a standard script for the nurse to relay this information to the provider to help expedite and streamline the antibiotic prescription process. And so once you make all these great interventions, it's very important to start tracking more information about whether your interventions are being successful. So it's important to perform reviews on resident medical records for new antibiotic starts to determine the why and the how. So looking at the clinical assessment, any documentation, and antibiotic selection, and determining whether they were in line with those facility-specific guidelines for antimicrobial prescribing that you've implemented. And so when conducted over time, this monitoring process will assess whether antibiotic prescribing policies are being followed by staff and clinicians. Beyond that, you can assess your stewardship impact. So you can look at whether or not your target areas are having an effect. You can look at adverse outcomes and costs. We know that antibiotics are not benign. They're definitely associated with several adverse effects, as well as definitely additional costs. And then there are multiple ways to just track the amount of antibiotic that's being used. And so there's a really good chart here. I'm not going to go into all these individual metrics, but you can see you have multiple options when determining how to track your antibiotic usage. And then finally, once you track all that data, you want to make sure that you report it. So again, going back to your interdisciplinary culture of stewardship, all these people, we've made them leaders, we've empowered them, we've made them accountable, and it's definitely time to share with them what you've found. So if your interventions are working, that's awesome. Share that success with them and encourage them to continue the good work. If there are additional areas for opportunity, you can, report these out and discuss ideas for next steps with the entire group. So it's definitely encouraged that you not only present to your leadership, but you also go back to your nurses, your providers, and your patients and family and let them know all the work that's going into appropriate antibiotic use at your facility. And then beyond reporting within your facility, the CDC is working closely with many nursing homes to develop an antibiotic use reporting option, so the AU reporting option. And this is within the CDC's National Healthcare Safety Network, or NISN. And so this option allows for a standardized antibiotic use data, and you would submit this electronically. And so this can actually be used to help you benchmark your antibiotic usage against other facilities. And it's also useful to support kind of a global antibiotic stewardship effort and help the CDC kind of evaluate how antibiotics are being used. And so we've talked about education throughout this entire presentation, but again, getting everyone involved with our antimicrobial stewardship. And so as you are developing interventions, tracking and reporting to your clinicians, make sure you're sharing their prescribing patterns, potentially doing a peer comparison, and making sure that they're in line with facility-specific guidelines. Our nursing staff, again, these are our frontline stewards. So these are the ones that are assessing your patient and evaluating whether or not they need to call the provider for an antibiotic. So really empowering and educating your nursing staff. This is key to your antimicrobial stewardship program. Educating your families and residents. So making sure that they know, whether or not their family member may need an antibiotic and what to monitor for. And then also residents, making sure they know what questions to ask when they're prescribed an antibiotic, making sure that they, know to ask for an indication and duration and what their potential side effects are. And so you don't have to reinvent the wheel when it comes to all these education methods. So there are multiple organizations that have put together really beautiful handouts and posters to provide education to all those different populations. So the CDC on the left, this is an example of one of their patient or family member handouts. And so they highlight questions to ask and again, trying to get everyone involved in this culture of stewardship. I mentioned AHRQ and all of the education resources that they have available for nurses. And then multiple other governing bodies and even health system specific resources are available. And so I've included those links there for your reference. So we had our core elements. You can see we took a lot of ideas from inpatient stewardship, outpatient stewardship, and tried to apply them to the long-term care setting. And then November of this year, the Centers for Medicare and Medicaid Services made this an actual rule. It's a requirement now. And so the rule very clearly states that long-term care facilities must develop an infection prevention and control program that includes an antibiotic stewardship program and designate at least one infection preventionist. And that these stewardship programs should include antibiotic use protocols and systems for monitoring. And you're in luck because we've talked a lot about exactly how to do that and what resources are available. So I'm definitely not going to read you all the components of this new rule, but you can see as we go through, a lot of these themes are very similar to those core elements. So you can see underneath composition, they are creating their multidisciplinary, interdisciplinary culture of stewardship with your medical director, your pharmacist, and nursing leadership. They talk about monitoring, especially on patient transfer, and providing provider feedback and defining what frequency and mechanism you're going to use for that feedback. They talk about what to include, signs and symptoms, indication, doses and duration, and then developing antibiotic use protocols specific to disease states. And then finally, implementation. So one of the resources that I absolutely had to share with you is this template for antibiotic stewardship policy for post-acute and long-term care settings. And so this is an actual publication from AMDA, which is the Society for Post-Acute and Long-Term Care Medicine. And they created this publication out of multiple requests for assistance with antibiotic stewardship in the long-term care facility. And so in this publication, you can find a template for setting up your stewardship program. Resources, multiple are available there, including your general stewardship principles, policies, antibiotic use protocols, how to measure and monitor, and even more education for your family and residents. And there are details throughout, including suggestions for implementations of all of the key points that we've talked about in this presentation. So key points, we mentioned that up to 75% of antimicrobial use in long-term care facilities is either inappropriate or unnecessary. The CDC core elements and the new CMS rule for stewardship provide guidance on approaches to reduce suboptimal antimicrobial use. And again, it's important, pick your high yield disease state target. So target your low-hanging fruit specific to your facility. It's important to educate, get everyone on the team and create a culture of stewardship. And then most importantly, empower your frontline nurses and consulting pharmacists to perform your daily ASP activities. So I want to thank you all for listening and participating in our webinar. If you are interested in receiving CE credit for the presentation, please visit the NCAP website for instructions. I hope you enjoyed our presentation and have a great rest of your day.